Welcome and thanks for pressing play. This episode of WarDocs was made possible by a partnership with the Defense Strategies Institute's OpMed TV and was recorded at the 2024 Operational Medicine Symposium in San Antonio. These interviews focus on optimizing military medicine through the modernization and implementation of policies, education, training, research, and development. We also explore emerging technologies to enhance the health, strength, and survivability of warfighters. Welcome to this special episode of WarDocs in partnership with OpMed TV. I'm Dr. Doug Soderdahl, retired Army urologist, and I'm joined today by Captain Lynelle Boamah, and she is the Director of Maritime Operations for BUMED. Thanks for being with us today.
Thank you so much for having me.
So tell us a little bit about what your job entails and how it relates to operational medicine.
So at the Bureau of Medicine and Surgery, I'm the Director of Maritime Operations. So I basically oversee the force generation effort for our expeditionary medicine platform. So we have teams that we've designed to be able to go out into theater, whether it be air, land, or sea, or under the sea, to provide damage control resuscitation and damage control surgery in support of the fleet and the fleet marine forces, as well as the joint force. So I oversee the efforts of planning, the education and training, so some force development, and then ultimately force generation, and eventually sustainment. That's the other job that we have at BUMED, is to sustain those teams while they're out.
So my background is Army, so I don't have the experience of trying to cover the vast expanse of an ocean. So
yes.
What are the unique challenges in providing medical care at sea?
So providing medical care at sea, honestly, isn't any different, if you will, than providing medical care in a fixed structure. Inside of our ships, even our submarines, but I'll just focus currently on ships. We have medical spaces that are designed for equipment that you would see in any operating room ashore. We have teams that are trained, same surgical techs, same surgical teams that work in the MTF structure. Facilities can do those same things ashore. What's different is there are power requirements for the ship. There are, of course, that motion that you might feel if you're at sea and you have to take out an appendix. So there are maneuvers that the ship's captain will do so that we can have like a stable environment in the operating room. And then the ship's engineer also is uniquely able to kind of funnel some of the energy requirements over to the medical equipment if that's needed. Depends on how much work we have to do. You're performing medical procedures in an industrial environment, and so there are challenges there as well with temperature, maintaining an environment so that the patient can be warm. The anesthesiologist at the head of the table has everything that they need. The environment has enough lighting and all of that. I'm trying to think of other unique opportunities for greatness when we are providing surgery at sea. But those are probably the bigger kind of tactical challenges. The other thing that you may not think about is how to get the patients to the operating room. So in the shipboard environment, there are small spaces that you have to maneuver through with patients on stretchers. When we do our mass casualty exercises, for example, on the ship, it's an all hands on deck effort. Actually, the other sailors who aren't medical at all learn triage. They learn through the tactical combat casualty care course, how to lift patients on litters, put them on a litter, stabilize them, and move them kind of, in a chain along the ship, the hull of the ship, to get into the operating room.
Well, it's funny, we recently interviewed a Navy surgeon who talked about doing appendectomies on an aircraft carrier. And
Right.
one of the unique things was they had to ask the captain said,
Oh,
hey,
yes.
do we need to do anything special to
Special.
not rock the boat? And he's like, oh, do whatever you need to do. It's okay. One of the things that intrigues me, though, is that triage is, we get damage control really from the Navy of when a ship gets damaged. You do damage control of taking care of the
Right.
ship. So what do you do when, let's say you're a non-corpsman, just a non-medical person, can't get from their area of the ship with an injured personnel to wherever they need to go? Are they prepared to do, I guess, a prolonged field care where they just can't, because of whatever's going on with the ship, they can't get them to where they need to go?
So every sailor, and when we have our Marines on board, is a first responder. I mentioned the tactical combat casualty care training. That's for every sailor and every Marine, no matter their rate or their job. So they're all trained to be first responders. So they can do basic life-saving techniques and maintain, if the patient is otherwise still able to, there are some patients that unfortunately will not be able to save, but hopefully the majority is going to be able to benefit from the first responder training that the Marines and the sailors on board have. And then that's until the corpsman or the independent duty corpsman, our baby docs would refer to them as corpsmen, and the independent duty corpsman, or if there are docs on board, the larger ships can get to that area. So the damage control teams are put into action to shore up wherever there's a breach so that you can make that bridge over from one part of the ship to another to get to the wounded warriors.
So you mentioned that not all the ships, not all the submarines have doctors and nurses on board,
Correct.
but they all have a corpsman. How are those corpsmen trained in an environment, let's say on a submarine, where it's not easy to get to help? How much training do they get to take care of patients in that environment?
So in that environment, that's a unique skill set. And so corpsmen who are assigned to submarines have more training than corpsmen who would be assigned to an amphibious spaceship or an aircraft carrier. I'll just use submarines as an example. There'll be an independent duty corpsman who has experience in hyperbaric medicine. They have that specialized training that they receive prior to getting to the ship. And that's done right here in San Antonio at Corman A School and C School. There are different levels of the trauma combat casualty care. There are different tiers, rather, of that training that are required for certain capabilities. So our corpsmen, everyone has the basics, but our corpsmen in those environments who are expected to provide care until you can get from a Role 1 to a Role 2 capability, have the Tier 3 training. That's all coming online. That's a DoD mandate, not just for Navy corpsmen, but for medics throughout our military, so that we can all level up. Right now, our corpsmen and some of our expeditionary teams are training in our civilian military partnerships. The corpsmen, some of them are at LA Trauma, others are up at UPenn, and then Cook County, we also have civilian military partnerships there to train our expeditionary teams. But the basics for our corpsmen is that they will have TCCC training. We're working on paramedic training, all of our corpsmen, and I'll mention that tomorrow because we'll need advocacy, and that requires time, money, but that's the goal, is to have them all be paramedic trained.
So one of the unique things about Navy medicine that I really like is the humanitarian part of the global health engagements with the mercy and the comfort. Tell us a little about how are those experiences different from, let's say, in combat and taking care of combat wounded?
I don't know if they're actually that much different. Right now in peacetime, That platform, we call it the TAH platform, that the hospital ships are a great opportunity for us to really rehearse. We may be going into Southeast Asia, for example, on the Mercy, that's West Coast
Right.
base, to teach disaster preparedness, to help the countries to prepare, and then to also maybe provide some humanitarian assistance if that's needed. But at the same time, when we're underway, when we're moving between ports or when we first get underway, we're underway for a couple of weeks. Oh boy, those are great opportunities for us to rehearse mass casualty, triage, moving patients in by air, moving patients by boat, small boat, or even our medium-sized vessels into the hospital ship, because the hospital ship is a Role 3 capability, just like a land-based hospital, only on the water. So those missions provide us an opportunity to rehearse what it would be like in a real life wartime scenario. The hospital ship wouldn't be front line, so it's not going to be the same thing as what our Role 1 Corman capability would be, like providing prolonged casualty care. You're going to get more definitive care on one of those ships, but it's a great chance to practice those skills and all of the procedures and processes that are in place to move patients from one part of the ship to another as they're getting treated for their wounds.
Now, I've seen some recent things in the news about new designs for hospital ships,
Yeah.
and maybe even smaller, ships that were specifically for medical indications.
Right.
Can you tell us about those at all?
Tomorrow I'll actually have a slide, a picture of the Expeditionary Medical Facility Bethesda. Medical ship, sorry, EMS Bethesda is the first of the newer prototypes for the more agile, scalable hospital ship. Not to replace the hospital ship, but to add to the fleet, if you will, of hospital ships. The one that we have out that's already been christened, already working through her trials, and just about ready to come out and be assigned her first mission is the Expeditionary Fast Transport ship called the USNS Cody. USNS Cody is a military Sea Lift Command ship that actually has been outfitted with a medical package. So we have operating rooms, and we also have recovery rooms, and we have rooms to provide acute care. So you can actually do both damage control resuscitation and surgery on this new ship. It's a gray hull ship. It's not the white ship with the red cross like
Right.
the EMS Bethesda, but that's what we've got out right now. It's actually, she can get into the littorals, so more shallow waters, and can also participate in patient movement. Can actually land one of our MV-22 helicopters on her flight deck. So we can do patient movement, transport, and we can also move supplies as well with the EPF flight to USNS Cody.
And how far can those helicopters fly from the ship to wherever they need to go?
The ship, the helicopters, that's not my area of expertise, but I think they've got a long range. I think so the ship has a long range and can go up to, I think, 30, 35 knots, and can get into the littorals. And if I squeeze my memory, I think it won't fail me. I've got 90 miles, but don't quote me on that.
Okay.
For the SH-60 or the MH-60 helicopters, and I think a lot longer for the MB-22.
Right. And so those ships obviously,
Or those aircraft.
right. And so if you're doing an appendectomy on one of those, you may want to pay more attention to, because you're going 35
To
knots.
the maneuvering.
Right.
Yes, and so that's a great point. When we have these emergencies that occur on board, you have to communicate. That's what the the role of the senior medical officer in the ship is to be that consultant, that trusted agent for the ship's commanding officer, and go up and talk to your skipper and say, this is something that can't wait until we get into another, along our planned movement of the ship. So the navigator, the ship's navigator, under the authority of the ship's captain, they recalculate the planned movement so that the surgery can take place. They plan it for the time it's going to take, and then if any recovery is needed. It's a coordinated effort. We can't just start operating. It has to be coordinated with the commanding officer and the staff.
Tell me a little bit about your personal journey into Navy medicine. What drew you into Navy medicine in the first place?
Oh, that's a fun story. I grew up in Baltimore City, very poor area, not a lot of opportunities. So I knew I wanted to be a doctor from the time I was maybe 5 years old. As the time came for me to go off to college, did that. And then as the time came for me to apply to medical school, my sister was a Navy yeoman. She was on a ship, and I'll never forget, she said, Lynelle, you've got to look at the Navy. The officers are living very, very well. Long story short, she encouraged me to look at Navy as an option to pay for medical school and also to have a lifestyle. After almost 29 years in the Navy, never regretted 1 minute with the encouragement of my family. My husband, Charles, is like biggest advocate for me to be doing this, and my mom, and then my grandmom, God rest her soul, was a patriot. She was the impetus for lots of us. My brother is a Naval Academy grad, and then we had a Sea Cadet, and my younger brother, and then of course my sister.
So for those listeners who may not know, what kind of opportunities are there to specialize as a doctor?
Oh my gosh. So I think a lot of people are nervous about becoming military physicians because they're afraid they're gonna go off to war and never see their families and all. But the Navy and other services, we have all of the STEM careers. You can be a doc, a scientist, an engineer, mathematician, you can be a physicist. All of these things help us to stay ready for the next, all of those specialties together help us to stay ready. I'm a pediatric gastroenterologist doing all of this. And so the sky is the limit. We have all of the medical specialties represented in the Navy, as well as all of the surgical specialties. We have brain surgeons, heart transplant surgeons, heart surgeons. I don't know about heart transplant surgeons, maybe heart surgeons. And then we have our own uniformed services medical school. So lots of opportunities. Come and join us. We're preparing our warriors to be successful in the maritime battlefield, and it's a super exciting time right now to be serving at the Bureau of Medicine and Surgery as well.
So tell me, as a pediatric GI doc, you've been in for 29 years. Now I'm sure that there's the siren call in the civilian sector to come over, join us, and we'll pay you lots of money. But what kept you in uniform for 29 years?
Have you been listening to my phone calls or something? Actually, what's kept me in is about 10 years ago, I decided that, hey, there's a lot of the Navy I haven't seen yet. Let me go and dibble and dabble a little bit. I got to be an executive officer and a commanding officer and work at the U.S. 3rd Fleet as the fleet surgeon, chief medical officer. And then this opportunity came up at the Bureau of Medicine and Surgery to help with this future planning for the fight, the next fight. I couldn't say no. Yes, there are the calls. They're getting louder and louder to join the private sector, but I'm dedicated to this mission, to seeing America win. And I also have an almost new ensign coming out, another Boamah. Josh is going to be graduating from the Naval Academy in a couple of months. And so I'm doing this for them as well.
Well, that's a great legacy. Well, we've been speaking with Captain Lynelle Boamah on this special edition of WarDocs podcast in collaboration with OpMed TV. Lynelle, thank you so much for your time, and thank you for your service.
Thank you so much.
Great talking to you.
Nice to talk to you.
Thank you for tuning in to this special episode of WarDocs, made possible by a partnership with the Defense Strategies Institute's OpMed TV. To stay connected with Team WarDocs, visit our website at wardocspodcast.com. Follow us on social media for updates and subscribe to our WarDocs YouTube channel for more engaging content. Your support helps us continue to document the experiences and contributions of military medicine professionals as we honor the legacy and preserve the history of military medicine for the next generation.